So, in the previous class, we have discussed few things. Let us recapitulate because we have discussed. We will be talking about National Strategic Plan. The second portion is a very important thing. Tuberculosis is something which has not appeared in your examinations since quite some time. So that is the reason, and it is a program which is government is emphasizing a lot. So that's why in the previous class I spoke about some latest developments with respect to National Strategic Plan. With respect to tuberculosis control. In fact, from the concept of tuberculosis control, we have moved along to the concept of tuberculosis elimination by 2050. So this may be, the goal may be very ambitious, but achievable. So some important changes that have been made with respect to the diagnosis of tuberculosis is that introduction of CBR NAT, liquid culture media and solid culture media, a cascade of these tests with respect to the laboratory diagnosis I am telling. So, of course, all of these invariably are backed by AFB staining. Not that AFB has gone out of circulation, but only the thing is, when a person is found AFB negative, then along with CBNAT we are doing AFB also. Along with liquid culture media we are doing AFB also. AFB is the definitive evidence even today also. Please remember this point with respect to the lab diagnosis. And apart from that, I don't want to elaborate much. And with respect to the public health activities to detect tuberculosis, from a position of passive surveillance, we have moved along to a position of active surveillance in certain groups. The urban slums, the prison inmates, alcoholics, persons with diabetes, persons with tuberculosis, with HIV/AIDS. So now we are taking up active surveillance for tuberculosis. So these are the migrant labor. So these are the people, special groups, occupational groups, which are being put under surveillance through active surveillance. We are conducting active surveillance for the detection. And third thing, very important change which has taken place is, previously there were fixed dose combinations, but now the entire composition of fixed dose combinations now are based upon weight bands. That is, variation of the fixed dose combinations, they themselves are a larger variety of FDCs, fixed dose combinations have been introduced basing upon the weight band. And another important thing is universal drug sensitivity testing. Of course, this has been taken up as a objective. Of course, and to a very great extent we have succeeded. That is, especially CBNAT itself will give drug sensitivity to INH. And then now line probe assay is being included in order to detect resistance to rifampicin, INH. And CBNAT is good enough to detect rifampicin resistance. So these are, we can say in a way, it is a highly justifiable in view of the fact that India carries nearly 25% of the load of MDR tuberculosis in the world. And afterwards, now this, along with this, the concept of adherence, treatment adherence, monitoring of food treatment adherence of TB patient to the drug regimen has come up. So now I have explained you in the previous class. As soon as the patient removes the tablet and takes it into his hand, he is supposed to uh, a particular cell phone number will pop up in his phone number, contact number will pop up in his phone. He has to give a missed call to that contact number. Then only it is considered that the patient has taken the tablet. If the patient has if the missed call doesn't go, for instance, I have not taken the drug on that particular day, then naturally missed call will not go to the treatment monitoring unit, which is electronically monitored. And then from the unit, a call will come to the patient, through automated call system, and reminds him, you please take the drugs. So in that manner, so in order to improve, and now there is increased dependence on private sector for tuberculosis notification. It is not only the government departments which take up tuberculosis notification, but now it is private practitioners also are supposed to take up notification of tuberculosis. One app has been developed, what we call as Nikshay app. Nikshay, that app's name is Nikshay, and that will facilitate very easy transmission of information from the practitioner to the district unit of district tuberculosis control unit. So these are the major and salient changes which have come about in the very program. Now, apart from that, there are some more things which have been introduced, especially to improve the social support system of the patient. Because tuberculosis patient requires social support system, a good social support system, in order to ensure that there is good compliance to the regimen and good conversion rate. So direct benefits transfers. Providing treatment enables in the form of financial incentives and nutritional support can provide for increased adherence and treatment success rates. So studies conducted all over the world, they have proved that to meet these twin objectives of adherence and treatment support, the program has launched Direct Benefits Transfer (DBT) scheme to financially aid tuberculosis. The DBT is implemented by a smart card linked to Aadhaar. Every tuberculosis patient is given a smart card and it is linked to Aadhaar. This provides a tamper-proof storage of user and account identity. It allows for a comprehensive multi-sectoral, multi-scheme benefit. This is benefits that are given are not only financial benefits, but they fall into other sectors also. To treatment care incentives. So pharmacovigilance activities. With Government of India vision as a long-term guide, the program defined objective of 2017-2025 is to strengthen linkages with the pharmacovigilance program of India for monitoring, identification and detection of signals. So key affected populations, just now I have told you. So which are the key affected populations? Key affected populations is a disadvantaged group of people as compared to others, mainly on account of their reduced access to medical services and the underlying determinants of health. Vulnerable, underserved or populations at risk of TB infection and illness constitute a challenge for TB control. Insofar as TB is concerned, this can be segregated into following broad groups. This is very important. Prisoners, sex workers, slum dwellers, minors, hospital visitors, healthcare workers and community health workers. People who are having increased exposure to TB due to where they live or work. These are the people. And then people who have limited access to quality TB services. This is another broad group. So migrant workers, women in settings with gender disparity, children, physically challenged, tribals and populations living in hard-to-reach areas, refugees or internally displaced people, illegal migrants and undocumented migrants. So people at increased risk of TB because of biological or behavioral factors that compromise immune function. People with HIV/AIDS, people who have diabetes or who have silicosis, who undergo immunosuppressive therapy, are undernourished, use tobacco, suffer from alcohol use disorders, and inject drugs. All these people, because their very body or biological system itself is prone to tuberculosis. So all these three groups, again I am repeating, this is a very, very important slide. So people who have increased exposure to TB due to where they live or work, prisoners, sex workers, slum dwellers, minors, hospital visitors, healthcare workers, and community health workers. These are the people. And now people who have limited access to quality TV services, they are migrant workers, women in settings with gender disparity, children, physically challenged persons, tribals and population living in hard to reach areas, refugees or internally displaced people, illegal minors, and undocumented migrants. People at increased risk of TB because of biological or behavioral factors that compromise immune function. So people who live with HIV/AIDS, those who have diabetes or silicosis, are undergoing immunosuppressive therapy, are undernourished, and heavy tobacco users suffer from alcohol use disorders and inject drugs. All these are at increased biological risk. Now there are certain strategic interventions which are being implemented. What are they? Strategic interventions. So, strategies for reducing the burden of TB among people living with HIV/AIDS. So, intensified case finding activities in HIV care settings. Program will emphasize on use of a simplified clinical algorithm for TB screening test. TB screening that relies on the absence or presence of 4 clinical symptoms: current cough, weight loss, fever, and night sweats, to identify people eligible for further diagnostic workup of TB. Also, rapid molecular tests, just now I have mentioned CBNAT, will be offered to all presumptive TB cases among people living with HIV/AIDS for early diagnosis of TB in settings such as ART centers, Link ART Plus Center, Link ART centers, and integrated counseling with testing centers. These are all HIV network and targeted intervention projects. All of them are HIV network. So TB prevention among people living with HIV. Isoniazid preventive therapy strategy for prevention of TB among people living with HIV to be implemented nationwide by 2017. Early initiation of ART. All people living with HIV with less than 500 CD4 count will be eligible for the ART. Considering this, people living with HIV already registered in pre-ART care, additional 1,50,000 patients will require to be started on ART. Additionally, nearly 50,000 patients will be added annually per year. And now, second is, just now I have referred to it, patient support system. What are the details? A good patient support plan is imperative for treatment success and will be developed at the time of initiation of treatment. This support will include the following: initial and frequent follow-up counseling of the patient and family members, supervision of treatment by a trained treatment supporter, a health worker or community volunteer, locally managed additional nutritional support, retrieval of treatment interrupters, and screening for adverse reactions, and appropriate social support scheme, psychosocial support, comorbidity management, and follow-up laboratory investigations. So another important thing, just now I have mentioned, they are direct benefit transfers. So what are those and what are the different sectors participating in that? First of all, Aadhaar acts as the unique identifier for parents undergoing treatment. And now social welfare schemes link patients to existing social welfare schemes to seek support. That is food security schemes and all those things. And then next is Nikshay. Nikshay will provide patient information to central TB unit and other social services schemes. And then Pradhan Mantri Jan Dhan Yojana. Pradhan Mantri Jan Dhan Yojana has accelerated spread of accessibility to banking services across the nations, and every tuberculosis patient is given some transport allowance so as to facilitate his transport from his house to the tuberculosis center. And so every month, so under Pradhan Mantri Jan Dhan Yojana, directly into his account only money will be transferred. And then Central Tuberculosis Division, of course, it has got inputs such as diagnostic services and all those things. So these are the different aspects. So the main purpose of all this is reducing the out-of-pocket expenditure for TB patients. This is very important. So what are the components of that? So cost of treatment borne by the government, cost of travel borne by the government, and nutrition. So a certain allowance every month is posted into the account of the patient. So nutrition, and then wage loss. So I think as far as I know, so nothing much is being done to compensate wage loss except those services which are already available to ESI or otherwise in certain occupational health services of individual organizations. And out of, so this is so this cost of diagnosis, cost of treatment, cost of travel, nutrition, and weight loss. So nutrition support for TB patients. So what is the kind of nutrition support which we give? So a population's nutritional profile is an important determinant of its TB incidence. Ultimately, reduction of TB burden in India and its elimination will require improving the nutritional status of the country as a whole. So the vicious cycle of undernutrition and tuberculosis, I think already you are familiar with this. I won't undernutrition, impaired cell-mediated immunity, tuberculosis, and anorexia, inflammation, and cytokine liberation, and again further undernutrition. So nutritional status of adult patients with TB in India. Data from NICSAI shows that median weight of TB patients is 43 kg and median weight in women is 38 kg. Whereas as expected, the average weight of 55 and 49. So data from large cohort of rural central India, median weight in men is again something like that only, 42 kg. Median BMI in men is 16 kilograms per meter square, and median weight in women 34.1 kilograms, and median BMI in women is 15 kg per meter square. So recommended food assistance. Say, in fact, what is being done in Telangana is to put some money. They are not supplying subsidized food. So food item is wheat, millet. So these are different packages, nutritional packages which are suggested. All these things you cannot remember. But you should know that nutrition support is being given to tuberculosis patients. You should remember this. And it has got nearly 52 grams of protein and 1080 calories and then 250 grams, totally 7.5 kilograms of wheat and millet, wheat or millet, and then or 7 kg of rice, groundnuts and edible oil. So prevention of tuberculosis. So scale up airborne infection control measures at healthcare facilities. It is healthcare facilities where maximum transmission of tuberculosis can occur now with so scale up airborne, especially this is required to prevent tuberculosis in healthcare personnel. So scale up airborne infection control measures at healthcare facilities. Treatment for latent TB infection in contacts of bacteriologically confirmed cases and addressing social determinants of TB through intersectoral approach. So challenges at community level, social habits, cough etiquette not being followed. Now with this COVID-19, more and more people are realizing the importance of cough etiquette and indiscriminate spitting and then sneezing without covering face. Alcoholics and mentally challenged patients and delay in reaching the health facility for specific time. These are all the hindrances which people face at the community level. And now, apart from that, there are special groups, so who are likely to be deprived of anti-tuberculosis activities, services. So again, I have told you, and I have read twice. What are the special groups? Migrant population, backward areas, and tribal pockets, and then old age homes, poor homes, children homes, jails, hard to reach areas, and delay in diagnosis in comorbid conditions like diabetes, HIV, cancer, etc. And then, so challenges at institutional level, outpatient facility, patients with chest infection at outpatient settings. So overcrowding, mixing of patients in queues and waiting areas. For instance, a diabetic and a tuberculosis, MDR tuberculosis patient may stand in the same queue. That should not be the case. There should be a separate outpatient counter for tuberculosis patients. So inpatient facility, cough screening, separation, fast tracking, mask and counseling provision missing. Infectious patients getting admitted in general wards and cough etiquettes not followed in wards and overcrowding in the wards. So all these are the factors. So which have to be taken care of to improve or to prevent tuberculosis through patient facilities. So solutions at institutional level, develop cough corners or counters, posting specific staff for fast tracking and providing masks, and providing N95 masks for hospital staff, advocacy, communication and social mobilization, and implementation of airborne infection control in all settings. So institutional setting and solutions. Separate inpatient facility for drug-resistant TB cases. This is very important. And AIC at ART centers. And then proper disposal of infective material, early diagnosis and initiation of treatment, personal and protective equipment for laboratory staff, and renovation of wards to improve ventilation, and periodic screening of the staff. So these are several steps involved. So nutritional requirements in TB patients, 40 calories of energy per kilogram of body weight, and 1.2 to 1.5 grams of protein per kilogram of body weight. So TB infection control in healthcare in congregate settings. The National Airborne Infection Control Committee, with representations from medical colleges, National Communicable Disease Control Cell, and then National AIDS Organization, National AIDS Control Organization, and then WHO, Architects and PWD engineers was established in 2008. So this is an intermixed group where engineers are present and the doctors also are present. So pilot testing of operational feasibility and effectiveness of the guidelines have been conducted in the states of West Bengal, Gujarat and Andhra Pradesh, and baseline assessments have been conducted in 35 healthcare facilities. So contact tracing in RNTCP, contact screening has been a clinical function with the cursory programmatic monitoring. In this NSP, contact tracing will be made more rigorous, expansive and accountable. The end result expected is that most TB patients will have their contact screened with secondary cases detected and treated. So contact investigation. All close contacts, especially household contacts, will be screened for TB using chest X-rays. In case of pediatric TB patients, reverse contact tracing for search of any active TB case in the household of the child also must be undertaken. So particular attention will be paid to contacts with the highest susceptibility to TB infection. I told those key populations. So since the transmission can happen from index case to the contact at any time, all contacts of TB patients must be evaluated. Use of chest X-rays upfront for screening of contacts will be prioritized during the National Strategic Plan period. Setting specific screening approaches, for example, in prisons, urban slums, etc., according to the RNTCP guidelines will be undertaken. So, preventive therapy, latent TB infection treatment. TB infection is the seed bed for developing TB disease and continued transmission. The lifetime risk of reactivation of LTBI in healthy HIV uninfected individuals is 10%, with 5% developing TB disease during the first 2 to 5 years after infection. ART reduces the risk of TB by approximately 2/3. The selection of the risk group. So people living with HIV again. So for all such people, we are giving isoniazid preventive therapy. Children are more susceptible to TB infection, more likely to develop active TB disease soon after infection, and more likely to develop severe forms of disseminated TB. Children below 6 years of age who are close contacts of a TB patient, so they are eligible for this isoniazid preventive therapy. The dose of INH for preventive therapy is 10 milligrams per kg body weight administered daily for a minimum period of 6 months. The INH tablets will be collected on monthly basis. The contacts will be closely monitored for TB symptoms. In addition to the above, INH preventive therapy will be considered in following situations. For all HIV infected children who either had a known exposure to an infectious TB case or tuberculosis skin test positive but have no active TB disease. All TST positive children who are receiving immunosuppressive therapy, example, children with nephrotic syndrome, acute leukemia, etc. A child born to mother who was diagnosed to have TB in pregnancy will receive prophylaxis for 6 months, provided congenital TB has been ruled out. So BCG vaccination can be given at birth even if INH preventive therapy is planned. Build. What does it mean in a national strategic plan? Undertake critical management reforms, restructuring of HR and financial norms, pathways for private sector participation in order to improve efficiency, effectiveness and accountability. What does it entail? Build synergies with existing health service delivery mechanisms under urban health mission and plan for integration of services. Reform and restructure human resource development in TB program to align with the enhanced program needs for surveillance, participation of private sector and community participation. Strengthen RNTCP's regulatory capacity to control TB drugs through appropriate laws, regulations and policies. This is one area. Now we are giving anti-tuberculosis drugs are being sold without any proper prescription in the market. This is one area which is very, very important. Position TB high on the health and development agenda of the nation to ensure adequate resources, greater demand for and universal access to TB care services. How it can be achieved? Urban TB control systems, health systems strengthening, advocacy and communications and social mobilization, surveillance, monitoring and evaluation, research and technical advice. So the most important of these things is urban TB control systems, and then surveillance, monitoring and evaluation. These and research and technical assistance. These are the three things which are very, very important. And even this advocacy, communication and social mobilization, it is very difficult to achieve. We have not made much progress in this aspect. The strategic interventions of TB control in urban areas during the National Strategic Plan period include institutional arrangement, planning, private sector engagement, social mobilization campaign, and primary healthcare services, referral services, especially with respect to the MDR tuberculosis cases, active case finding in urban slums, and involvement of partners and NGOs. The convergent action with other stakeholders, community monitoring and research. Health system strengthening. There are separate programs catering to the rural areas under the National Rural Health Mission. Equivalent urban initiatives are within the purview of National Urban Health Mission. This is what is required. It is a burning problem because definitely there is a lot of migration from a rural area to urban area. Some people stay back in the urban areas permanently, and some people go back and come back once again. So this kind of a migration from rural areas to urban areas is being created under tremendous economic pressure. So naturally, more and more people, vulnerable people, accumulate in the urban areas. So that is the very important. So development of strong linkages with the National Health Mission to improve access to diagnostic and treatment services. Though in rural areas, the tremendous success of National Health Mission has facilitated the delivery of quality diagnostic and treatment services closer to the community. The urban areas remain a challenge. Strategic interventions, bold policy initiatives. The TB policy will be aligned to the national health policy and the necessary regulations under TB policy. Mandatory notification of all TB patients, enactment of laws. Mandatory notification of all TB patients, this has already been done. Assured access to quality diagnosis and treatment as a standard of care through all healthcare providers. So it is now the onus of action is both on the private practitioners and also district administration. The moment through his Nikshay app in his cell phone, the moment the private practitioner sends information, it is the responsibility of district tuberculosis officer to respond with alacrity and provide what are all the benefits that a new case is added. This is very important. And regulation of use of diagnostic tests and regulation ban on sale of anti-TB drugs in open market. Just now I was mentioning that. And no stigmatization for TB patients and families, etc. And right to access to public health care, compensations, and occupational screening, workplace interventions, and enforcement, immigration, admission to educational institutions. So strategic interventions are bold. This is over. So in the urban areas, the main problem is institutional arrangements, that is getting into touch with the private hospitals and all those things, and provide necessary information and logistical support to the doctors. And then planning the program itself, because urban areas keep on expanding. So every year probably the plan of activities has to be altered. And then private sector engagement, just now I have spoken about it. And social mobilization campaigns, that is in the urban areas, and also through targeted interventions you have to take up a campaign approach, social mobilization. And primary healthcare services, integration of anti-tuberculosis services with primary healthcare services. And then referral services to MDR tuberculosis patients. And active and extrapulmonary tuberculosis also. Active case finding in urban slums and involvement of partners and NGOs. Convergent action with other stakeholders and community monitoring and research. So how it can be achieved? Urban TB control systems, health system strengthening, and these are the things. And now government has set up one national tuberculosis elimination board. It is proposed to create an apex body, facilitate policy development, coordinate multi-sectoral involvement, and overview the implementation of the strategy to move towards TB elimination. Prime Minister as patron, Union Minister for Health and Family Welfare as chairperson, and Secretary Health as member secretary. So this board, the National TB Elimination Board, it is proposed. So advocacy, communication and social mobilization. So although distinct from one or another, advocacy, communication and social mobilization are most effective when used together. That is all you have to carry out the simultaneously. Advocacy, communication and social mobilization. Key ACSM priorities. Government of India should declare TB as a public health emergency and combat it in a campaign mode, increase budgetary provisions and rebrand RNTCP, engage drivers, stakeholders, especially elected representatives, empower and engage TB community, and the trained spokesperson of the program should routinely and safely. So, surveillance, monitoring, and evaluation. Establish TB surveillance system at district, state, and national level. Monitor the performance of TB control activities and feed this information into the decision-making cycle, and then identify and descriptive vulnerable populations at increased risk of TB and unfavorable prognosis, to which targeted public health activities will be addressed. Now, funding and research. So, increase the allotment, that is one of the important things. So, this national strategic plan, which I have been talking, comes into force from 2017. Implementing agency will continue to be the Central TB Division, the controller of aid accounts and audit of Department of Economic Affairs, Ministry of Finance, Government of India will maintain a special account for tuberculosis control. This will be a centrally sponsored scheme wherein the state health societies, district health societies, municipal corporation health societies will maintain a separate accounts. Now all these things I don't want to go into the details. Now I have given you the broad outline. What I have given is more than sufficient. If you remember and retain all these things, please go through the park also, 24th edition. It also is giving a lot of importance, useful importance. So with this, I have completed tuberculosis. In the next class, I will make a revision of environmental sanitation and things like that. Thank you.